prominence of the middle third of the left heart border is not always an abnormality of clinical significance, and not always it represents an enlarged pulmonary trunk. This is a patient with the so-called pseudo mitral configuration. That is a heart that is not enlarged, a small aortic knob, convex middle third of the left heart border. However, the pulmonary markings are radiographically normal. This individual had no cardiac disease, and young individuals, particularly if they practice aerobic exercise, the so-called athlete's heart, may show prominence of the pulmonary trunk, and this is not a pathological condition. In corrected transposition of the great arteries, that means a physiological correction of the circulation, we may see a bulging in the middle third of the left heart border, close to the left ventricular arc. And you can see in this case that the pulmonary vascularity is normal, and the patient had corrected transposition of the great arteries. And this middle third of the left heart border is formed by the ascending aorta, not by the pulmonary trunk. This is a diagram of a correct transposition of the great arteries. Remember that the term transposition means a malrelationship between the pulmonary trunk and the aorta as to their ascending portion, the proximal portion of these two vessels. In correct transposition, the aorta is ventral to the pulmonary trunk and to the left, and arises from an anatomically right ventricle, although this ventricle receives arterialized blood. In corrected transposition of the great arteries, sometimes there is a so-called juxtaposition of the appendages. In other words, the right and left auricular appendage come together, as illustrated in this diagram. So the bulge that we may see in this angiogram, we can see evidence of corrected transposition of the great arteries. The bottom right shows the ascending aorta to the left and ventral to the pulmonary trunk, arising from the arterial ventricle. We note in the top images the left-sided position of the right auricular appendage, RAA, and note also the position of the left auricular appendage, which projects below the right. So this is to show that occasionally in corrected transposition, a bulge may be seen along the left heart border that is superimposed or below the bulge produced by the abnormally located ascending aorta. Another case of corrected transposition of the great arteries in an infant, note cardiomegaly, and note the bulge in the middle third of the left heart border. The vascularity of the lung was slightly increased. A pulmonary angiogram following the injection of the right ventricular cavity, which is anatomically a left ventricle. Note its smooth inner outline. Shows the medial position of the pulmonary trunk, which branches into a right and left pulmonary artery. This is the venous phase of the same injection that shows opacification of the left atrium, which receives the pulmonary veins. Note that it connects with an arterial ventricle, which anatomically is a right ventricle, from which the ascending aorta arises and occupies the middle third of the left heart border. Another example of corrected transposition of the great arteries. This is an interesting case of a patient with cyanosis without heart murmur. What are the possibilities? One is the microarteriovenous fistula syndrome, which is usually part of the Rendu-Weber-Osler syndrome. Patients will have epistaxis and may have no murmurs, but have cyanosis. And the second cause of cyanosis without murmur is a persistent left superior vena cava draining into the left atrium. Note in this frontal chest rentgenogram a prominent middle third of the left heart border, and there is an ill-defined density that is noted slightly lateral to the arch of the aorta. An angiographic study was performed, and one can see the catheter in the pulmonary trunk. This is a levoangiocardiograph in the top left, which shows opacification of the left atrium and evidence of a left to right shunt with opacification of the right atrium. The top right image shows the shadow of the left superior vena cava. A persistent left superior vena cava connects the cephalad with the nominate vein, and caudally it usually ends blindly, in which case it is called a persistent left vertical vein, or can drain in the coronary sinus or in the right atrium. But in this case, the left superior vena cava drained in the left atrium, and that was the reason for a right to left shunt, and did not cause any murmur. The patient was operated, the septal defect was closed, and the persistent left superior vena cava was ligated at its junction with the left atrium. So the bottom images are post-operative angiograms of this patient. Another cause of a bulge in the region of the middle arch of the left heart border is a pericardial defect. In this case, the patient was asymptomatic, and note the convexity of the middle arch of the left heart border. What could it be? It could be an enlarged pulmonary trunk, like a poststenotic dilatation from pulmonic stenosis. It could be a slight left to right shunt, the reflection of pulmonary hypertension, an ascending aorta in a patient with corrected transposition of the great arteries. A pulmonary angiogram was performed, and it showed a normal branching of the pulmonary artery. The density was not related to the pulmonary trunk. In the levoangiocardiograph, that is the opacification of the left heart chambers, one can see a prominent left auricular appendage outlined by arrows, and this was the cause of the bulge. This is virtually pathognomonic of a partial pericardial defect. When one fluoroscopes these individuals, one may see active pulsation along the left heart border, and a proximity of the heart to the lung, because actually we're seeing a cardiac structure projecting beyond the pericardium and banging against the medial aspect of the left lung. Another example of a partial pericardial defect, note the convexity of the middle third of the left heart border with normal pulmonary vasculature. Here we can see an enlarged, abnormally positioned left auricular appendage, and what herniated through the pericardial defect was the left auricular appendage, and that accounted for the convexity of the middle third of the left heart. Another cause of a bulge along the left heart border is a pericardial cyst, as demonstrated in this patient. Echocardiography would be the procedure of choice. Masses of the mediastinum, like thymic lesions, can appear close to the heart and simulate a bulging pulmonary trunk. Constrictive pericarditis is often associated with a small, quiet, calcified heart, but this is seen probably in less than 50% of patients. Constrictive pericarditis may appear diffusely involving the heart, or may selectively narrow structures of the heart. For example, on the right side, it can occur at the level of the right atrioventricular groove and cause a relative obstruction to the egress of blood from the superior vena cava to the right atrium. So systemic venous hypertension may result from this location of the constriction. On the left side, the constriction can be at the level of the left atrioventricular valve and then simulate hemodynamically the findings of mitral stenosis. In this case, there was evidence of pulmonary hypertension. The patient was thought to have a precapillary hypertension. The cause of the hypertension was constrictive pericarditis with a selective involvement of the left atrioventricular groove. So actually the prominent middle third of the left heart border was due to an enlarged pulmonary trunk.